In preparation for the appointment bonding sevens, the old term used to be called band sevens. We very rarely band teeth now, with the exception of when we're fitting expanders. So the nurse is setting up the tray. Let's just go through a couple of common things. We're going to ask this child to wear elastics. So with the Damon system, we have drop-in hooks, which allows the easy placement of elastics and doesn't affect oral hygiene. In the past, all our brackets were pre-welded with hooks, which meant that when we didn't need to wear the elastic, it became a hygiene problem. This is a Damon 1425 copper nitrile wire. These are the stops, and we'll be running through where exactly to crimp that wire. These wires we normally keep in the freezer. Why? Because we want them at the appropriate temperature, so they're easy to use in the mouth. When they undergo their martensitic transformation and reach mouth temperature, then the wire actually becomes active. Here we have our distal end cutter, and it's our safety holding distal end cutter. When the wire is placed in the mouth, we'll show you how to cut the end of that wire. And this is our universal plier, which allows us to actually place the wire in and outside the mouth. The only thing you've got to be careful of with the Damon system, see how this plier has serrations on the end? These serrations, if you use them on the very light wires, particularly the 013s, they put little grooves in the wire. And if you look at what Ormco have now said, they've said do not use pliers with serrations on the end, because it will cause the wire to fracture prematurely. I don't see that in the 1425 copper nitrile or the 1825 copper nitrile, but certainly in the round wires. So this is the distal end cutting plier, the safety holding. So if we cut here, you can see it still keeps that wire in place, stops it from flying down the back of the mouth. Now this is our ligature cutter. When do we use the ligature cutter? We do a lot of under ties in the Damon system. Some people know that as a lace back. Basically, we want to group teeth together. We're going to show you that exercise today. And this is the plier that we use. Don't use that to debond. After a while, these are not sharp. Rather than throw them in the bin, we then can use that plier if you want to take brackets off. And I'm going to show you that technique. This is our needle holder, mouthhouse plier, and you can see it's very easy to lock it, hold it in a position. What do we use this for? In the old days, this is the way we deliver the O-ring onto the tooth. Nowadays, this plier would be used when we're doing our under ties to get our spool of wire and engage and then tie it together and then spin it round. This is our ligature director or ligature tucker. You'll see this being used in this patient to make sure that once we've cut the end of the under tie wire, nothing's poking, we just push that in. Now, I really want to talk about the glue we use. It's green glue. What I like about green glue, well, first of all, it's for metal brackets only. If you use green glue on any of the clear brackets, it's going to defeat the purpose of them being clear. We use blue glue for that. In the technique, we're going to bond the sevens for this patient. You'll see the etching procedure, 30 seconds per tooth, the rinsing procedure. Now, with the rinsing procedure, in the past we did 5 seconds. I find that's not enough, and if you leave any of the phosphoric acid on the tooth, that's a big cause for bond failure. So we like to do 10 seconds minimum in the rinsing. We then dry. It'd be nice if you have a Molar system. The Molar hair dryer works well to keep the moist air away from the tooth. Then we're going to show you how to place the right amount of green glue. If you put too much green glue like that, and then you press it hard against the tooth, the flash takes ages to clean up. What I like about the green glue is once you have cured it, you can then see the area you need to clean because it is green, and we're going to show you how to use a multi-fluted tungsten carbide burr in the cleanup process of the flash. We like using LED lights technology now. Many dentists are still using VLC technology, which might be fine for the composites, but when you're doing a bonding on many teeth, you really want the LED platform, and we're using the Dematron lights in that regard. So this procedure will be a technique guide on how to bond the terminal molar, how to then open the bite with resin, glass ionomer cement, how to engage the wire, how to put the stops on the wire, how to show the kid the elastic pattern that's required. We're also going to show you the use of our night-eye coil spring. We use night-eye coil spring when there's no room for a tooth, and you can place this night-eye coil spring on the Damon copper night-eye wire. There's different sizes of coil. If you look here, you can see that this is a 012, that's the thickness. The diameter is 036. So an 036 on a round wire will bounce around. So there's also the opportunity of getting an 020 spool. And the 020 spool is great for the 014 wires, etc. When you start jumping up to your 1425s and 1825s, then we go for that diameter. Remember, it's made of nickel titanium, not stainless steel. If you use stainless steel, it overpowers the system. We want light forces in the Damon system. So when you're buying spool wire, the variables are going to be stainless steel, TMA, or night-eye. Go for the night-eye. The variables are going to be diameter. I like going for the 012 and in two sizes, in a 020 or an 036. And we'll go through more about that. I'm just going to show you how to measure the right amount of coil spring. When you want to create space for a blocked out tooth, you measure the distance between the brackets and you add half a bracket width. Maximum is one bracket width. Any more than that, you're going to overpower the system. The coil is going to basically irritate the patient's lip, and you're going to have another emergency on your hand. As far as the etch we use, nothing magical there. It's our 37% phosphoric acid gel. We like it to be coloured so we can see it on the tooth, and we use this as an applicator. They're disposable because it allows us to put the etch exactly in one position. In the past, when we'd use a little micro brush, you find that sort of etch would go everywhere and make it much harder in cleanup time because etched enamel absorbs stain very quickly. People are asking, why is this part of our kit? Basically, when we want to minimize emergencies, we can anneal the end of the wire till it becomes red hot. That way it's soft so that in the mouth we can put a permanent bend in it. And that's important in some of these night-eye wires. Now remember, in the Damon system, you don't want to bend it too tight, because then as the arch expansion occurs, the wire wants to mesialize, and your bend is going to prevent that from happening. So in an ideal world, you'd cut the wire flush, and that would certainly be the case in a 1425 and an 1825. In the round wires, in the 014s and the 013s and the 016s, sometimes they become too flexible, and they're the major cause of emergencies in our practice. Getting back to our bonding protocol for the green glue, please remember, after you have etched and rinsed and dried, the green glue only goes on the mesh base of the bracket. You never put ortho solo on that bracket, because if you do, you're going to negate the effect of the mesh in the first place to improve the mechanical retention. So this is what we're using. It's an 8th generation bonding agent known as Ortho Solo. And the Ortho Solo applied with our micro brush is the important step for the tooth preparation. Why is it 8th generation? Why is it important? The 8th generation has a calcium affinity, so you don't just get the mechanical retention from the etching, you also get a chemical retention from the calcium bonds. So the concept here is you have a dry tooth. You will now apply the Ortho Solo on the region of the tooth that you're going to bond to, but you put the green glue on the mesh base. So we're now going to be bonding the second molar for this patient. We're applying our phosphoric acid in the gel form and leaving that for 30 seconds. Then we are rinsing for a good 10 seconds, if not longer. We then keep the area dry and apply Ortho Solo. The Ortho Solo is placed, and now you do not light cure the Ortho Solo. That's another fallacy people think you need to do. And you never put Ortho Solo on the base of the bracket. On the base of the bracket now, we're using the green glue. And the idea here, so this is a molar tube held in Keats tweezers. I like the Keats tweezers for molar tubes because they give you a better grip. We put just enough that when we work it onto the mesh, we actually push it into the mesh of the bracket. Okay.
That's a little bit, Josh.
So patting it into the molar tube. Okay. Now we're going to place that molar tube onto the terminal molar.
See the excess.
Then we will...
even that little bit of amount that I put on, you still get a bit of excess when I push it on. That still was too much.
So you can see here, just to show you what happens when you put too much green glue, as you push, you can see the amount of residue that's around there. So clean that residue off before you light cure, save you a lot of chairside time, because this stuff sets like concrete, and having to remove it, there's a good chance you're going to pop your molar tube off.
And the green glue will go clear once we light cure.
Once you light cure the green glue, it will go to clear. And then when you want to clean up, you can ask the patient to rinse with cold water. It'll go back to green. That's what we like about it. Minimal cleanup time, easy to see the excess flash. So with curing the molar tube, research has indicated the closer you can get the Dentron to the bracket, the better as far as curing. Almost touching the bracket is ideal. So you can see now that we've set that molar tube, the green has gone clear. Just a point on timing of the curing light. If you're using the older type curing lights, the visible light cure VLCs, you are looking at putting the bracket on and then using 10 seconds for clear brackets, 20 seconds for metal brackets, and 30 seconds for molar tube. So it's a time-consuming process, and sometimes you'll need to do those from the mesial and the distal, or from the occlusal and the gingival. Using this new technology, which is the concentrated cool beam LED or halogen light, it's 5 seconds for all bracket types and 10 seconds for the molar tubes. Okay, so continuing on from the second heading, which is bonding sevens, we now are going to introduce patient Murray. Murray is a high angle class 2 patient, so when we bond his molars, we want to bond them more occlusal. If you bond the molar tube gingival for a high angle patient, the molar is going to extrude. For every millimetre of molar extrusion, you're going to get 3 millimetres of open bite worsening. So if I can just show you where Murray started. Murray has a high angle growth pattern, backward rotator, and he had a high palate, stream crowding. Traditional mechanics would have been 4 on the floor. Based on his profile, what we're doing is developing his upper arch. So we've used an expander with occlusal coverage, what we know as a bonded hyrax. So if I show you his lateral cephalometric radiograph, you can see the vertical growth pattern. We can see the large adenoids that are present, and referral to ear, nose and throat doctor had recommended adenectomy and tonsillectomy to help with his nasal breathing, which I think will have a big impact on the future growth as well as the closure of our open bite. So Murray is currently in a upper 1825 copper nitrile wire. My normal progression with a bonded hyrax is to develop the arch to the size I need, then bracket the 3-3 using the bonded hyrax as an anchor source. When the 3-3 are level, we remove the bonded hyrax and we bond the 4, 5 and 6. We try and leave the 7s off in high angle cases because they tend to open the bite, but if they're really rotated or badly malaligned, we've got to pick them up. When we pick them up, we try and pick them up in a lighter wire and we bond them as occlusally as we can. So in this exercise, we're going to show a number of clinical skills with the Damon system, the bonding of the molar, the use of bite turbos, but posterior bite turbos because of the vertical. We're going to show the opening and closing of the gates. We're going to show some under ties, some core springs, some drop-in hooks for the elastic pattern. On that point, being a high angle class 2, his elastic pattern will always be short class 2. And short class 2 will be from the upper cuspids down to the lower 4s and 5s.
So I'm going to open here.
Okay, so we've put in Molar retractors. What we like about the Molar retractor is the fact that it gives you a great field of view. The inner part of the Molar retractor, which hasn't been fitted yet, keeps their tongue out of the way, so even if the patient swallows, they tend to swallow forward, the saliva is pulled posteriorly, and you can see that how nicely this case has turned out already in such a short time using the combination of orthopedics and the Damon system. So let's start by simple removal of the wire and opening of the gate.
Yep.
Using a Damon opening tool. It's curved on one side and straight on the other.
Engage the little divot in the bracket. We push in on it, push against the tooth, and I use a second finger just to open the gate gently. And like so, you can do it like that.
Now closing the gate, you can actually close with your fingers, if we can just demonstrate that.
Yep.
The main thing is the placement of the stop, and we'd like the stop to be placed mesial and distal of one bracket. We normally like that to be the tooth that is anterior of the crowding, and normally that tooth should not be a rotated tooth. So in this situation, his teeth would line up fairly well, but we'd probably put a stop mesial and distal of the upper left central incisor. Okay, so that is the wire now removed. That's the upper 1825 coming out of the mouth. In the lower, the wire's already been removed. I think what we will now demonstrate is what we showed outside the mouth, which is the etching, the rinsing, the bonding of the molar tube.
Yeah, for the rest of we're going to go.
And so we're going to start with some pumice. Now the pumice has to have no fluoride because fluoride will affect the setting of the composite, the green glue. So we're going to pumice his lower sevens.
Yep.
So there's the 7. What we're doing now, we're placing the tongue retractor off the Molar system. This is the most important thing because as the patient swallows, in most retraction systems other than Molar, saliva wets your enamel. So all your isolation, your etching, etc. goes out the window.
Open nice and wide.
So we ask the patient to put their tongue into the groove, thank you. And then you can see the slats which allow this to slide into the Molar retractor. It's almost like a pin and tube system. There we go.
It's in there.
Okay. So it's clicked in now, and then we push it distally, and that puts the rubber tubing away from the tooth. Same on the other side. This rubber tubing will then be connected to a low-speed suction, and you can see then you have the low-speed evacuator on all the time. All the saliva coming from the back of the mouth is then evacuated. So it's a very, very good design. It gives us good isolation, allows saliva not to impede what we're doing. So again, we can see here how the Molar is being fitted so that it's not going to get in the way. And we're then going to have the slow speed evacuator connecting
the level for the cotton roll. Open there. Okay, so it's a bit more comfortable for our patient. Close together.
Yeah, that's good. So again, now just showing clinically what we were doing outside the mouth. 30 seconds of etching. Now you can already see resin placed on the 6. That resin is going to prevent molar extrusion. So now at least 10 seconds of etching of the enamel. You get that nice frosted appearance. Then we're going to bond with Ortho Solo. Remember, Ortho Solo is placed only on the etched enamel, not on the bracket base. And placing it occlusally because of the high angle. Using our Keat tweezers, and now using a probe just to position correctly. Removing excess flash. Remember, before light curing, right now you can see it as green, and now we are light curing. Good.
So we check our bracket. So that's tough as nails. In there, also.
Now we're going to repeat the process on the patient's right side. In the past, we were always reluctant to bond terminal molars for fear of them debonding, and we would band them, which becomes a hygiene nightmare, plus not comfortable for the patient with separators. Thanks to the advent of Ortho Solo and green glue, we have total confidence bonding in the mouth, even when we place in our strongest wires. Not that we're going to do it in his case because he's a vertical grower, but if he was brachyfacial, we could easily put in a 1925 stainless steel without fear of that molar tube debonding. So we're changing now from a 014 copper nitride to a 1425 copper nitride. I find that when you bond 7s, if you use a round wire between the 6 and 7, because of the increased interbracket distance, you're bound to have emergencies. So we tend to bond the 7s when we do 014 wire, but not engage the 7s with the 014. Alternatively, you can bond 6 to 6 and do what we're doing today, picking up the 7s. We're using the old wire as a rough guide, a size, but of course allowing extra space for the bonding of the terminal molar. So now we'll be using a non-serrated vine guard plier, and we start by placing it into the molar tube off the 6. Now placing the wire on the other side. This is why it's important that these wires are kept in the freezer right up until they go into the mouth, make it much easier to use. So we're going into the 6. Sometimes if you have a very thick wire, maybe an 1825 or 1925, and you're having difficulty getting into the molar tube, just get a high-speed diamond burr and bevel the end of the wire so it's behaving like a round wire for insertion purposes. So we're into the 6 now, we're engaging into the 7. So after we've placed the lower wire, we're going to demonstrate an under tie upper 3 to 3. That under tie upper 3 to 3 will be with a long preformed lace back. It will show you then how to use a math house to keep that section taut, then a ligature cutter and ligature tucker, and then the point to remember is that when you're using the Damon system, you should be putting your under ties before your main wire. If you try and over tie with the Damon system, you tend to get a lot of rotation of the teeth. You show the stop where it's been placed there. So you can see mesial and distal of the canine. We have a archwire stop, and that will prevent the wire from sliding left to right. Because of a low friction bracket system, without that stop we have more emergencies with the wire wanting to swing to one side or the other.
Cut flush. Open.
So you see the extra wire there. We obviously don't want cheek irritations. At the same time, we don't want that wire mesializing as it aligns and coming out of the molar tube. That's not normally a problem with a long molar tube like this. So we'll cut this flush, and that way the Damon system can still do its transverse development. In the lower, most of the changes you're going to see are the posterior teeth uprighting, and that's why in a high angle case such as this, we would not go past a 1425 wire. People ask, well, why are you in a 1425 versus a round wire? The round wire will give us good leveling and aligning, but will not allow the round wire will give us good leveling and aligning, but will not allow good rotation control. So that's why if we go to a 1425, we get the best of both worlds. So we're demonstrating now the under tie technique.
So this can have its own little heading.
So you show the long ligature wire. Yep. And you can see the way it's designed at the end to engage one side. So we'll put this in the mouth now in the upper 3 to 3.
So the little curved bit goes on open body and chin up. Goes around like so. We'll make sure it's nice and firm. There we go, over, under, over, under.
Some people call this a figure of 8. Some people call this a lace back. The correct term is under tie because it's tied under the main wire. We used to use 010 ligature wire. I find that's very flimsy and it tends to break. We now use an 012 ligature wire. This is stainless steel material. We buy this off the spool, or to make life easier, it can be preformed such as this. Now we're going to use a Mathhouse plier, and the Mathhouse plier will allow us to put tension on the under tie. So we'll pull this under tie now, in this case distally, and then start tying it together. And the important tip is, once you've got it tight, you'll use a ligature director in between every contact point just to make sure that it's fully engaged. Yep. In this case, put pressure with the finger.
There you go. Sharpen the finger out like a rabbi head.
Yep. So again, seeing here, this is the under tie, tight, and making sure there's no loosening, because if this is loose, you'll get emergencies as the wire will loosen up and disengage.
You can see here, as I push this one, we look at this spot, you see the tension decrease. So slightly.
So the reason we're under tying is because we're going to place drop-in hooks on our cuspid. In this case, the cuspid already has a hook. If you don't have any drop-in hooks, and if you want to spread the force of your elastics more evenly on the wire, then you can use crimpable hooks. And again, that's something that we'll demonstrate outside the mouth. You can use crimpable hooks, ideally on 1425 and 1825. It's a little bit harder on the round wire, just simply because of the surface area to crimp. So this is your under tie now. It's under tying upper 3 to 3. And we're putting back in the 1825 copper night tie. The reason I'm not putting a 1925 stainless steel with posted hooks is because we haven't ordered an x-ray as yet to check the roots of the teeth. And if you go to stainless steel, you won't be able to reposition brackets. So again, using a vine guard plier without serrated tips to engage the upper 1825 copper night tie, passing through the 6 and 7 tubes. People ask, why don't you use self-ligating molar tubes? We find that although it might be easier placing the wire, they're very bulky and they really irritate the cheek. So we like using the non-self-ligating molar tubes. There's a little tube for the 7 called a PIX tube, P-I-X. Pros of that are it's very, very gentle on the cheek. A disadvantage, it doesn't have its own little hook. So if you want to run an elastic to a 7, then you're going to have to use a different type of bondable molar tube. We like the Orthos design. There's many like it on the market. It's basically got a very good depth, a very thin bracket. So as a result, the patient comfort is improved. So now we have in the mouth a upper 1825 copper night tie and a lower 1425 copper nitai. If this was a neutral angle or a deep bite brachyfacial patient, I'd wait to go to the lower 1825 copper nitride before ordering an OPG. Okay. So can you take all that with that?
Right, so I'm going to demonstrate the Damon drop-in hooks. And we're wearing some short class 2 elastics, so from the lower 5, 6 to the upper 3, 4s. So we'll drop the hook in. This is how the hooks come. And it's open nice.
I'll demonstrate a Kobayashi as well, just in case.
Yep.
You see the liquid tucker now being used. The hook is made of brass wire. It's very soft. So once it's engaged, just to stop it falling out, stop irritation, we just can tuck the leg inward. And on the other side, just to demonstrate another option, we can put what's called a Kobe tie. The Kobe tie is preformed here, and you can see how it's going to be engaged. And this is going to be engaged in this situation over the Damon bracket. So different options of elastics, crimpable hooks on the archwire, Kobayashis on the bracket, drop pins on the bracket. What direction of elastics? Straight from the Damon workbook. In a high angle case, short elastics. In a low angle case, long elastics. Long elastics definition from the molars to the canines. Short elastics from the canines to the premolars. So if I have a deep bite class 2 individual, I'll be using long class 2. On the round wire, we start with 2 ounce, then we progress to the mid-range wires, 1425, 1825 with 4 ounce, and then you finish on your stainless steel wires with 6 ounce elastics. So the elastic strength increases with the strength of the wire, but the elastic positioning is pretty much a act and react scenario. So we might start with bilateral class 2s, we then see the centerline shifting. Next visit we'll go to class 3 on one side, class 2 on another. When we start seeing an open bite appear, we might go to anterior trapezoidal or deltas. So basically, there's not one set of elastics throughout treatment. The skill level in orthodontics, and what makes it much harder to teach than, say, crown and bridge or implants, is it's not just a one-visit appointment. It's like playing golf. You've got 18 holes. Here we have the equivalent number of appointments, and what we need to do at every appointment is reevaluate our treatment objectives. So the biggest skill level in orthodontics is not so much attending a course on diagnosis, although that's important. It's being able to look at a case under supervision from the day the brackets are placed till the brackets come off, and getting a clinical supervisor or tutor to be able to read and react for you until you develop that clinical skill. So here the elastics going on the lower 5s and 4s up to the canine. This is called a short class 2. If we look back to the original diagnosis of this patient, it was a high angle class 2 crowded case.
Close. Lower 4, 5. Up to upright.
So we're going to show a short class 2, upper 3s down to lower 4, 5. Just show that on both sides.
Okay.
Just can you show any smiles?
Yep, put back in.
So high angle patient, class 2. It's from the
lower 3, or 5, 4.
Lower 4, 5 to upper 3. So it's a class 2 pull A delta would be upper 3 down to lower 3/4, which is more a vertical pull. So this is helping our high angle, but also still helping our class 2 component.
And open. And bite together. So taking an initial pull and this side. So open and close.
So just get a mirror so we can demonstrate to the patient how to wear the elastics. I find the good ability of having drop-in hooks, then the patient goes home, they remember where to wear the elastics. Also, you get a packet of elastics. I want Con to draw on there how the elastic pattern is. Can you hold that for me so I can just show you? You're doing okay?
Yeah.
Yeah, we're finished now. I just want to show you.
Sharp poking anywhere? Just got to fit.
No wires poking?
Uh,
Just rub your tongue around there. That's all
yeah,
good.
there's one in the top one there.
Yeah, right down the end?
Yeah.
Okay.
Yeah, right down the back.
Okay. I'll just polish it for you. Okay. So sometimes when you have a wire poking that's too small to cut with a distal end cutter, we use a high-speed diamond and just polish the end.
Yeah.
Now, we're just going to show you how to wear the elastics. You want to just hold the mirror there?
Yeah. So have a look in the mirror. Push your head back. Okay. So you can see we've got two hooks on the braces down here. It is the last or second last and third last tooth up to the first tooth on the top.
Just show it for the video, the drawing on the packet.
Yep. And on our last the bottom. 1, 2, 3. 1, 1, 2, 3. It's going from the third to the second to the first. That's how it's ready. Two triangles like so. And that correlates to that. Chin up.